Welcome to part 2 of Pharmacokinetics and Pharmacodynamics, chapter 4, third lecture. This is part 2. Again, here is case history 4, digoxin, as we look at applying the principles of pharmacokinetics and pharmacodynamics to forensic toxicology. You'll see that we have a case history 4. That's about a 33-year-old white female who was admitted to the hospital after taking 60 digoxin tablets. Blood concentration at admission was 45 nanograms per milliliter digoxin. After activated charcoal was given 6 hours later, it was 18 nanograms per milliliter in blood. 1 hour after activated charcoal 6 hours later, it was 18 nanograms per milliliter in blood 1 hour before death. At autopsy, heart blood digoxin 27 hours after death was 36 nanograms per milliliter. So you can see we went from admission of 45 down to 18, and then after death it went back up to 36. Why was there an increase in blood digoxin after death? If you think about it, it was due to post-mortem release from heart muscle into the heart blood, which can happen in the case of digoxin. Let's look at the next case. When was the drug taken? Of course, before we get to the next case study, we'll take a look at a couple of principles here. The bioavailability of a drug, or the percent of the drug that reaches the site of action, is the result of competing processes of absorption and elimination. If a lot of the drug is metabolized in the liver or excreted in the bile, then bioavailability, when taken by mouth, will be low. Metabolism in the liver and renal excretion clear drugs from the body. The half-life, sometimes called T1 half, is the time it takes for the blood concentration or the amount of drug in the body to be reduced by 1/2. Here is a figure that illustrates the rate of absorption of alcohol from an empty GI tract to be about 0.1 grams per deciliter per hour. Now you can see the y-axis is grams per deciliter, blood alcohol concentration, sometimes CP, I think is what they're trying to show it as. And the x-axis is hours, time since drinking, and minutes or in time of hours. Also, you can look at it that way. This point right here is 60 minutes. So right about this is a point after 1 hour from ingestion. Again, showing that the rate of absorption of alcohol from an empty GI tract is about 0.1 grams per deciliter per hour. For alcohol, absorption period is assumed to be complete within 1 hour. Okay, now let's look at case history 5, secobarbital. An unresponsive 34-year-old male, 160 pounds, was found and transported to hospital where he died 3 days later. Blood samples taken at the hospital contained 47 milligrams per liter of secobarbital at admission, 41 milligrams per liter after 10 hours, 35 after 16 hours, 29 after 18 hours, 25 after 41 hours. Postmortem level was 14.2 milligrams per liter secobarbital. Plotting time versus blood concentration gave linear graph with slope that allowed half-life of 40 hours to be determined. At the decedent's home, a suicide note and 2 different prescriptions for 30 tablets of 100 milligrams secobarbital were found. Is this consistent with the hospital data? Before we leave this slide, let's note that it was 2 prescriptions of 30 tablets times 100 milligrams. That would be a total of 6,000 milligrams were available for ingestion. Looking at the next slide, you can see the calculated amount is close to the actual blood concentration found on admission. It was concluded that the decedent had taken the tablets several hours before being found. So here's the concentration in blood calculation using 6,000, which is what we predicted from the history. This is the volume and distribution, 1.75 liters per kilogram. This is 72.7 kilograms, the weight of a 160-pound person. And making the calculation, we calculated 47.17 milligrams per liter as to what the concentration in the blood would be. And that was very close to what was at admission, which was 47 milligrams per liter. So it was right on. So it was concluded that the decedent had taken the tablets several hours before being found. Okay, here's case history 6, speedballing, the combined use of cocaine and heroin. A 27-year-old woman was seen driving erratically at high speed and ran off the road. When police arrived, she was agitated and then rapidly fell asleep. A urine sample 3 hours after the incident was positive for both cocaine and opiate metabolites, morphine. Half-life of cocaine is 0.8 plus or minus 0.2 hours, while that of morphine is 1.9 plus or minus 0.5 hours. When taken at the same time, cocaine affects predominant immediately and then decreases after an hour, and then the narcotic effects of morphine predominate. Here is parent metabolite ratios. For drugs that are metabolized before elimination from the body, the ratio of parent drug to metabolite is a measure of the time elapsed since dose. This can be useful in forensic investigations. If we go back to case history 1, the ratio of free morphine to total morphine was 0.45 milligrams per liter divided by 0.7 milligrams per liter total morphine, which equals 64.3%. The significance of this is discussed on the next slide. Here is a table showing the rules developed by data mining software, taking a lot of data and trying to find principles that apply because of that data. But this figure does show the rules developed by data mining software for interpretation of morphine-involved deaths. It allows the determination of the time and cause of death. Looking at them, here is expert system rules for rapid death. These are things that are correlated or expected with rapid death. These are the information that's correlated with direct overdose. Percent unconjugated morphine is greater than 44% in a rapid death. Blood unconjugated morphine is greater than 0.09 to 0.21 micrograms per milliliter, depending on other drugs present in rapid death. Brain morphine is greater than 0.22 micrograms per milliliter in rapid death. And then all these are associated with direct overdose. Liver morphine is greater than 0.5 to 0.75 micrograms per gram of liver tissue. Blood unconjugated morphine is greater than 0.25 micrograms per milliliter. Brain morphine is greater than 0.08 micrograms per milliliter or greater than blood unconjugated morphine. Percent blood unconjugated morphine is greater than 37%. Frequency of use, chronic. So this figure shows the rules that have been developed. Since the ratio of free to total morphine was greater than 50% in case history number 1, this death was determined to be a rapid death occurring in less than 3 hours after dose. Also in case history 1, since morphine and 6-PAM or 6-monoacetylmorphine was present along the entire length of the deceased hair, it was concluded that she had been a chronic user of heroin. The cause of death was morphine overdose because the blood unconjugated morphine was greater than 0.24 milligrams per liter. The percent of blood unconjugated morphine was greater than 37%, and the frequency of use was chronic. Witnesses admitted that the woman had been given high-grade heroin and then collapsed suddenly. Going on, did the drug account for death or impairment? There are many tables of therapeutic, toxic, and fatal concentrations. And if you notice, therapeutic, toxic, fatal are going from lower to higher concentrations. Therapeutic doses and ranges are established throughout with very careful studies. Lethal or fatal concentrations are only gathered from published case reports that just give the highest concentration that was encountered. Another consideration in correlating a blood concentration for pharmacological effect is the time course of the drug's effect or pharmacodynamics. Many drugs will show different effects at different blood concentrations. The hysteresis curve for methamphetamine is shown on the next slide. Hysteresis is behavioral effects versus blood concentrations. And let's take a look at that. This is the hysteresis curve for amphetamine. Shortly after dosing, the predominant effects are euphoria, relief from fatigue, nervousness, stimulation. At a later time, the effects are confusion, paranoia, exhaustion. Observations of involuntary reflexes such as blood pressure, heart rate, temperature, pupil dilation, pupil diameter are more objective than types of behavior as in Figure 7. So vital signs and symptoms noted during a systematic drug recognition exam are important indicators of the pharmacological effects of blood concentration in a specific individual, even more so than the behavioral effects. In our last slide, here are some conclusions we can make. In forensic toxicology, the following information must be interpreted together. 1. History and observations made at the scene, at autopsy, or during the drug recognition evaluation. 2. Chemical test on appropriate specimens. And 3. Interpretation using pharmacology, pharmacokinetics, and pharmacodynamics. So we can collect a lot of information in 1 and 2, but it does take interpretation of the data based upon the history and whether those two are consistent with each other, as we've seen in these case histories. Thanks. See you later.